Welcome back, neurophiles. This is Dr. Ribinik. Let's talk about movement disorders. This video is rated MS for medical students due to basic concepts, clear language, and case-based examples. Medical student participation is advised. There are no relevant financial conflicts to disclose. Cases used in this talk were modified for teaching purposes. As always, we will start with a case. A case will introduce an abnormal movement, for which we will need special vocabulary. So, movement phenomenology is next. There's a specialized focused movement disorder examination that will help you identify major diagnostic signs, which will lead to the diagnosis of Parkinson's disease. Our patient may require treatment, and we will discuss early treatment options. Movement disorders often present with non-motor features, and we will review these features in Parkinson's disease. Once non-motor features show up, our differential broadens to include various disorders with Parkinsonism. And we will conclude by reviewing treatment principles for advancing disease. Use the chapter markers below to jump directly to any of these sections. Throughout this talk, I will be asking questions, so feel free to yell out answers at the screen. If you get the answer wrong, nobody will know. Besides, there are no wrong answers, just steps towards better understanding. We begin with a case. A case of a 57-year-old male. He has a history of hypertension and hypothyroidism. And he presents with a 2-year history of right arm shaking. He first noticed the symptoms in his right thumb, and they slowly progressed to involve the hand. The shaking occurs predominantly at rest and improves with movement. He denies changes in walking or balance, but admits to mildly decreased sense of smell and constipation. There are no changes in his sleep pattern. His medications include lisinopril and levothyroxine. Overall, this is a fairly mild presentation, so why is he in your office now? Well, he says that the arm shaking is now becoming bothersome. Movement disorders usually result from dysfunction of the motor and/or coordination pathways, but as with any lesions in neurology, appearance of symptoms depends on lesion location. A movement does not immediately translate to etiology. Many disorders causing lesions in the basal ganglia and coordination pathways can present with the same involuntary movements. But describing the abnormal movement, its clinical phenomenology, is a crucial first step in the diagnosis. Let's start by building our movement vocabulary. Movement disorders present with either too little movement, hypokinesis, or too much movement, hyperkinesis. Hypokinesis implies reduced movements in the absence of weakness. Of course, you would expect weak limbs not to move as much. Parkinsonism dominates the hypokinetic group. Hyperkinetic group includes Tremor, Dystonia, Chorea, Tics, and Myoclonus. Full disclosure, this is not an exhaustive list, but a good starting point. Also, this distinction is helpful for learning, but by no means specific. Many diseases have features of both hypo and hyperkinesia, due to the disorder itself or perhaps as a side effect of treatment. Let's start with Parkinsonism. Parkinsonism is a clinical syndrome presenting with bradykinesia, rigidity, and rest tremor. Postural instability is also often included, but let's defer discussing that for now. Bradykinesia is slowness of movement. The actions themselves are slower, but there's also slowness of initiating movement. In the arms, bradykinesia typically starts distally with decreased manual dexterity of the fingers. It's not surprising then that patients have difficulties with tasks that require precision, like buttoning buttons, tying shoelaces, or grasping pills. In the legs, foot dexterity is also decreased. Patients drag their legs when walking, taking shorter steps. Patients may also have difficulty standing up from a chair or getting out of a car without assistance. The movements are not only slowed, but also have reduced amplitude. For example, people with Parkinsonism swing their arms less when they walk. Bradykinesia also refers to reduction in most spontaneous semi-voluntary movements. This patient has limited facial expressions and delayed nasal speech.
January, February, March, April, May, June, July, August, September, October, November, December.
All right, now tell me the days of the week.
What?
Days of the week बोलो.
Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday.
Rigidity refers to stiffness or resistance of a limb when it's flexed passively. Agonist and antagonist muscles are basically activated simultaneously. So for example, a biceps is fighting against the triceps. Rigidity is usually contrasted with another type of increased tone, spasticity. Now, spasticity is not a movement disorder. Spasticity is essentially an exaggerated stretch reflex. Resistance is felt only when a muscle is stretched rapidly. The faster you stretch, the more resistance. Spasticity is velocity dependent. Rigidity is not. Spasticity is a type of increased tone that develops with subacute to chronic corticospinal tract damage. Spasticity, rigidity. Spasticity, rigidity. Corticospinal tract damage, basal ganglia damage. Okay, I'm done. Just kidding. Spasticity, rigidity. Tremor is the third component of Parkinsonism, and it can be a prominent early motor feature. Now, tremor is excessive movement, which places it squarely within the hyperkinetic category. Now, do you see what I mean when I say the two categories are not entirely exclusive? Yeah, I realize that it's a bit paradoxical that one of the most prominent features of a hypokinetic phenomenology is actually a hyperkinetic movement, but bear with me. Tremor is an involuntary, rhythmic, oscillatory movement of a body part. Antagonistic muscles are probably contracting synchronously. It is this rhythmicity that distinguishes it from other hyperkinetic movement disorders. In general, tremors are first classified by activating condition. Here's an example of a patient with Parkinsonism where tremor occurs at rest. Now, this tremor worsens with action. This patient has a condition called essential tremor. Notice how much difficulty this patient is having with using kitchen tools. Wow, that was a little too close for comfort. His tremor is rhythmic and regular. You can even count how many times the tomato oscillates in a second. Let me spare you, it's about 10 times, or 10 hertz, which would be considered moderate to high frequency. Next, dystonia. Unfortunately, to add to the confusion, dystonia is both the term for the phenomenon and also for the diseases where it occurs. Dystonia, the phenomenon, is characterized by intermittent or sustained muscle contractions causing abnormal, often repetitive movements and postures. This overcontraction of the muscles could be caused by a dysfunction of a motor network that involves the basal ganglia, the cerebellum, and the cerebral cortex. Here is an example of a patient with one of the most common adult-onset dystonias, cervical dystonia. The neck muscles turn the head intermittently in an unintended direction. Notice how the movements are patterned. They involve the same body region and have a consistent directional quality. This patient's neck turns to the right and hyperextends. Now, tremor is also patterned, but unlike dystonia, it involves rhythmic oscillations. You might also say there's a twisting quality to these movements, which is not always the case. Interestingly, about 2/3 of these patients can temporarily reduce or abolish these symptoms with a sensory trick, so-called geste antagoniste, antagonizing gesture. This person touches his cheek and the dystonic movements stop. It's almost miraculous. So dystonia's defining features are patterned movements and the sensory trick. In general, dystonic movements cannot be voluntarily suppressed. In fact, the opposite is true. They tend to be initiated or worsened by voluntary action. Sometimes these even occur only during a particular activity or task, such as writing or playing a musical instrument, but not during any other activity. This is an example of this task-specific dystonia. As this patient writes a sentence, his hand involuntarily flexes and supinates at the wrist. The thumb and index finger form a pincer grip with the extension of the index finger. The last 3 digits also flex. When dressing, the hand also assumes a dystonic posture.
And now,
It's very hard.
yeah, okay.
Okay, let's switch gears to chorea. Chorea presents as involuntary, brief, random, and irregular contractions. You probably heard that the word chorea derives from Latin and means dance. The randomness of movement is the key phenomenology, and it conveys an impression of restlessness to the observer. Movements have random and flowing quality and appear almost dance-like because people with chorea often incorporate the chorea into their normal movements, as if they were attempting to hide it. This is called parakinesia. Because of these irregular contractions, patients may have difficulty sustaining purposeful motor activities, such as tongue protrusion and hand grip.
Don't let it back in. Come on. Keep it out as long as you can, but let's count to 3. Go.
This is called
1.
motor impersistence.
1.
A patient with chorea may not be able to maintain tongue protrusion, and the tongue retracts back into the mouth after several seconds. Typical choreic movements tend to be distal, involving hands and fingers. If you're a Marvel fan, watch Scarlet Witch's finger movements as she casts her spells. Take away the red glow, make the movements much more subtle, make them involuntary, and you've got yourself a good example of chorea. Ballism is a variant of chorea, characterized by large amplitude flinking, kicking, involuntary movements involving proximal extremities. Ballism is most often unilateral, hence the term hemiballismus. Next, tics. Tics are sudden, rapid, recurrent, non-rhythmic, individually recognizable motor movements or vocalizations. Think of them as improvisational notes in a jazz melody. The culprit may be a disinhibition of the motor and limbic system because of a disturbance of the corticostriatothalamic cortical or mesolimbic circuit. Speaking of motor movements, this person touches his nose and mouth with the right hand, coughs, grimaces, and moves his neck from side to side. Vocal tics are usually simple noises.
And about 5 years ago, the vocal tics started, and the motor tics have gotten a lot more intense. I deal with addiction and alcohol abuse as well, and in the past 6 months since I have been sober, it's gotten dramatically worse, unmanageable.
Shouting obscenities or profanities, known as coprolalia, like in this case, is actually a rare phenomenon in tic disorders. Because these movements are repetitive and recognizable, some people with tics refer to them as their tic repertoire. Some other vocal phenomena include echolalia, repeating what others say, and palilalia, repeating the patient's own words or phrases. Most adults and over 1/3 of children with tics experience premonitory feelings. Vaguely defined as an urge, a mounting tension, pressure, or itch.
What I feel before I tic. Often before I tic, not 100% of the time, but often, I feel this buildup of pressure and sort of tension and just a feeling that I really can't describe that comes before I tic. Hey, and ticking releases that urge, and that's called the premonitory urge.
Many individuals can briefly suppress their tics, but the more a person tries to suppress a tic, the stronger the urge to perform it. Tics are also suggestible. Talking about tics in the presence of a person with a tic disorder may trigger their tics. Myoclonus. Myoclonus is a hyperkinetic involuntary movement that is uniquely very brief. We'll talk about what that means in a second. Myoclonus has a number of localizations, lesions to cortical and subcortical motor pathways, and even peripheral nerves. The sudden jerks of myoclonus are often described as lightning-like, bursts of less than 200 milliseconds. Myoclonus has a bewildering list of etiologies, from normal physiology to epilepsy, so-called epileptic myoclonus, hypoxic injury, neurodegeneration, inflammation, toxic metabolic insults, you name it. This particular patient unfortunately suffered a hypoxic injury. Her muscular contractions produce a so-called positive myoclonus, what you would think of as myoclonus based on the definition I provided. Now, this patient was simply asked to keep his hands up as if stopping traffic. Intermittently, his hand and finger extensors lose motor tone, and the hands begin to drop. He recognizes this is happening and engages the motor system to compensate. So the issue here is not an abnormal contraction, but rather a sudden loss of tone. This is called negative myoclonus, or asterixis. It is often seen with toxic metabolic derangements, and this person presented with toxic levels of anti-seizure medication phenytoin. Alright, let's summarize. Tremor is defined by rhythmic oscillations and is mostly brought on by action, outside of resting tremor of Parkinsonism, of course. Dystonia produces patterned, predictable movements and postures. Sensory trick may help, while action, especially certain tasks, may worsen dystonia. Movements in chorea are random, and patients often try to hide their chorea by incorporating it into their normal movements, which is called parkinesia. These random movements result in motor impersistence because they intrude on sustained purposeful motor activities, like protruding the tongue. Tics are non-rhythmic movements or vocalizations that are preceded by premonitory urge. They can be suppressed, but only briefly. Also, tics are suggestible. The lightning-like movements of myoclonus are its unique feature. Myoclonus can be positive, an involuntary contraction, or negative, a loss of tone with a compensatory contraction. Of course, life is rarely this simple. Patients may have combinations of movement phenomenologies. Dystonic tremor, for example. No two patients with a movement disorder are alike, and that's part of the subspecialty's charm. Now that we all speak the same movement disorder language, what phenomenology is our patient exhibiting? Rhythmic oscillations? That's right, this is tremor. This tremor occurs at rest, and you might remember that this is one of the major pillars of Parkinsonism. Let's learn to look for the other Parkinsonian signs. You know the general screening neurological exam. Mental status, cranial nerves, so on. But here, let's focus on a more detailed exam of the systems relevant to movement disorders, motor and coordination. By the way, I would like to acknowledge Dr. Kathleen Poston from Stanford and her patient Larry, who graciously provided videos for this section. Our patient has a tremor, so we might as well talk about that first. In general, tremors are classified by activating condition. They either emerge during action or during rest. Action tremor can become obvious when performing a movement, like trying to bring a cup of water to the mouth. That's called a kinetic tremor. If this kinetic tremor is most pronounced as the affected body part approaches its target, like on finger-to-nose testing, that is called an intention tremor. Action tremor could also be brought on by holding a specific posture or position, like holding the arms outstretched. These action tremor subcategories are not that important for you to understand, since many tremor disorders present with multiple action tremor types. These terms are being thrown around so often that I thought we would at least review them. They can serve as a mnemonic to remind you how to look for action tremor on exam. Notice how most videos shown earlier in the talk did not actually require an examiner to do anything. With movement phenomenology, observation is key. So you would likely start your exam by observing the patient as they rest their hands in their lap.
We want to get the patient's hands in a better position. And that's sort of on the side where they're relaxing their hands a little bit more. The reason for that is that they can actually do things to suppress the tremor by the positioning of their hands, where they can hold their hands, put their hands on their lap, even sit on their hands, and you might not see tremor.
And in this relaxed state, you can see that this patient has a resting tremor.
We basically would see a small movement in the thumb or in the fingers, or a rotational movement might come out while we're in this position. But this is a good position to look for hand tremor in.
Next, have the patient hold a posture. Keep their arms outstretched with fingers spread wide. Certain action tremors may be brought on by such postures. Finally, let's look for a tremor during action. We can ask the patient to perform the finger-to-nose maneuver, stretching the arm slowly and as far as possible.
So a couple things there. I'm having him reach his hand completely out because that will bring the tremor out more. I'm keeping my hand in a fixed position, so I'm not trying to see whether he can touch it in space. That's more of an ataxia part of the exam. What I'm really just focusing here on is tremor. I also need him to go slow enough that I can actually see the tremor, so I'm not trying to have him go as fast as possible. You might actually miss the tremor if you have the patient go too fast.
This gives us the best chance of catching the tremor if it's actually there. Tone can also be assessed at rest.
So Larry, I want you just to relax your arm as much as possible, and I'm literally holding the weight of his arm in my hand. I can feel the weight of the arm, so I know he's really relaxed.
The most sensitive region to look for rigidity is in the wrist. With passive movement, you will feel increased resistance throughout. It doesn't matter how fast or in which direction you move the limb, rigidity is not dependent on velocity or direction of movement. If you ask the patient to tap their knee with the opposite hand, or open and close the opposite hand at the same time as you're testing tone,
That's when I catch the rigidity. And here, it's just a little harder for me to get that full range of movement, but I'm able to get it. I can also catch it in the elbow here a little bit, but I have to do the activation maneuver because his medications are working so well.
By the way, you may have heard the term cogwheel rigidity. That's rigidity interrupted by a resting tremor, producing a ratchet-like effect. If a patient doesn't have tremor, they won't have cogwheeling. Next, let's use rapid alternating movements to assess for bradykinesia. Remember from the last section that bradykinesia is the most significant feature of Parkinsonism. For the upper extremity, the tests are finger tapping, which is the most sensitive.
Good, let's try the other hand.
Opening and closing a fist. We are really encouraging the patient to go as big as they can and as fast as they can. And wrist pronation supination.
Palm up, palm down, as fast as you can. Good, the left hand the same thing, up, down, up, down.
For the lower extremity, it's toe and heel tapping, and toe taps are more sensitive.
Keep your heel on the ground, and with your right foot, I want you to tap your toes big and fast. Good, and now let's try the left one. This one's a little harder.
If you're wondering what the normal speed and amplitude should be, try performing the movement yourself as control. In this example, Larry has bradykinesia. There is reduction in speed and amplitude of his movement. Finally, you need a detailed coordination and gait exam. Have the patient perform the finger-to-nose maneuver, but this time, move your finger to different positions and have the patient speed up. This increases the sensitivity of this maneuver for dysmetria. Next, can the patient stand from a chair without using the strength of their arms for assistance? Let's find out. Ask the patient to cross the arms on their chest and stand up. How did that go? If standing is relatively stable, time to attempt walking. A quick note, at this point, we're about to ask a potentially unsteady patient to perform maneuvers that may make them more unstable. So you have to be very careful and protect the patient at all costs. If they fall, it's completely on you. I guess better on you than the floor. While the patient is walking, observe step length, foot motion, arm swing, and turns. Patients with Parkinsonism may have short step length and stepping on a flat foot instead of a heel, decreased arm swing, and imbalanced turns. Let's say the patient you're examining appears steady so far. Time to raise the stakes. The pull test.
This one's real. I'm going to give you a tug. I'm going to want you to take 1 to 2 steps to catch yourself, and I'm right behind you. I won't let you fall. Ready? Good. Now I'm going to pull you a little harder.
Pull the patient backwards off their center of gravity. If they cannot correct their balance with several steps, then the test is abnormal. Patients who fail this test have postural instability and tend to retropulse, fall backwards. Okay, let's get back to our patient. Observation at rest revealed a mild tremor of the right hand and a less noticeable tremor in the left hand. When holding posture, tremor seems to disappear for a moment, but then reemerges. Rapid alternating movement testing showed a slight decrement in slowness of the left finger and toe taps. There was no slowness on the right side. Gait was generally normal, except for the mildly decreased left arm swing. Pull test was normal. There was no retropulsion. So, in our 57-year-old man with hypertension and hypothyroidism who presents with slowly progressive rest tremor, predominantly in the right hand, and mild bradykinesia on the left side, what is the pathological differential diagnosis? I can just hear you scream, Parkinson's disease! That's one condition. Hold your horses. Let's just go step by step. The main chief complaint here is tremor, so let's start with that. We already mentioned that tremors are classified as occurring during action or at rest. Resting tremor has a shorter list of causes, basically idiopathic Parkinson's disease, as in degeneration of dopaminergic neurons in substantia nigra. Parkinsonism can also be secondary to a structural brain lesion or another neurodegenerative condition, so-called atypical Parkinsonisms. These conditions usually present with other signs. We'll review these later in the talk. Action tremor has a wider pathological differential diagnosis, and it consists of essential tremor, drug-induced tremor, tremor induced by metabolic or endocrine derangements, enhanced physiologic tremor, tremor associated with a peripheral neuropathy, tremor associated with dystonia, and tremor resulting from damage to cerebellar outflow from the cerebellum to the thalamus, so-called cerebellar tremor. At your stage in the training, action tremors of any cause will look very similar at the bedside. So various causes of action tremor can really only be distinguished by additional signs and symptoms. For example, neuropathic tremor occurs when large myelinated peripheral nerve fibers become damaged. Think Guillain-Barré, diabetes, vitamin B12 deficiency, hereditary neuropathies. This type of tremor is thought to be due to muscle weakness and loss of proprioceptive inputs. Patients with neuropathic tremor will have other signs of neuropathy, like distal worse than proximal sensory motor deficits. Our patient doesn't have that. Dystonic tremor occurs in patients with dystonia. Remember dystonia? Of course not, that was like 10 minutes ago. Dystonia involves patterned, predictable movements that may be aborted by a sensory trick. Again, not our patient. Cerebellar tremor occurs in people with coordination deficits, ataxia, dysmetria. This is not the case. So we can already eliminate 3 major causes of action tremor from our differential. Most of us have some very low amplitude, high frequency physiologic action tremor. And that's normal. Physiologic tremor can become enhanced with anything that stimulates adrenergic activity, even anxiety of being in a doctor's office. But you wouldn't really expect physiologic tremor to be constant or to progressively worsen over years. Finally, certain metabolic disturbances such as hyperthyroidism and hypoglycemia may cause tremor. Typically, these conditions can be distinguished by accompanying symptoms: weight loss, palpitations, excessive sweating, heat intolerance, in the case of hyperthyroidism. Notice that our differential includes the 2 most prominent causes of isolated tremor: essential tremor and idiopathic Parkinson's disease. And speaking of isolated tremor, just for the sake of this exercise, pretend that our patient has prominent tremor, but the other symptoms are extremely subtle, so it looks like tremor is really the only symptom. Parkinsonian tremor occurs at rest and typically involves distal joints of the upper limb. The wrist pronates and supinates. Also, ball of the thumb may rub against the surface of the index and middle fingers in a circle, as if rolling a ball of dough. This is called pill rolling. Fun fact, back in the day, that's how pharmacists made pills from powdered drug and liquid binder. This pill rolling tremor is important because it operates simultaneously at multiple joints and in multiple planes, something unique to Parkinson's disease. Also, Parkinsonian tremor usually begins asymmetrically. Essential tremor occurs during action. Ask the patient to draw an Archimedes spiral. And you will quickly spot the jerkiness of the line. Ask the patient to hold arms outstretched, and the postural tremor becomes obvious. Ask the patient to drink from a glass of water, and be prepared for some splashing. Like in Parkinson's disease, essential tremor most often affects the hands and arms, while generally sparing the legs. Unlike Parkinson's, essential tremor is more symmetric. So, essential tremor is an action tremor that usually involves the upper extremities and the head and appears more symmetric. And tremor of Parkinson's disease is prominent at rest, usually involves the hands and fingers, and appears more asymmetric. Seems straightforward, right? Who would ever confuse the two? Okay, is this essential tremor or Parkinsonian tremor, and why? Difficult, isn't it? Patient is holding his hands outstretched. After a few seconds, the tremor seems to get worse. So, could this be the postural action tremor that is characteristic of essential tremor? The rest tremor in some patients with Parkinson's disease has a reemergent quality. You ask the patient to lift up their arms. The resting tremor improves during movement, but once the arms assume a new resting anti-gravity posture, the resting tremor comes back. This phenomenon of reemergence can complicate the diagnosis. We often have to rely on the presence of other subtle Parkinsonian features, bradykinesia, rigidity, to support the diagnosis of Parkinson's disease. Let's get back to our 57-year-old man with hypertension who presents with slowly progressive right hand rest tremor and mild bradykinesia on the left side. The pathological differential at this point includes Parkinson's disease. There is evidence of Parkinsonism. Essential tremor, which is actually the most common neurological disorder causing an action tremor and the most common movement disorder. Drug-induced tremor. There's a bewildering number of drug classes that induce tremor, including antiarrhythmics, antidepressants, anti-seizure medications, inhaled beta agonists, glucocorticoids, mood stabilizers, caffeine, and even our patient's thyroid hormone replacement, levothyroxine. Don't bother memorizing this list, just remember to first review medication history in people with new tremor. I guess this can also be enhanced physiologic tremor, but we decided that to be unlikely. You'd be quick to point out that our patient's bradykinesia is not a finding in essential drug-induced or enhanced physiologic tremor. To that I say, this is the real world. Slowness on the left side may be completely unrelated. Perhaps it was caused by a chronic small subcortical stroke. This patient has vascular risk factors, after all. So what's the next best step in the management? Most movement disorder diagnoses are made clinically. At the moment, there is no non-invasive diagnostic test to confirm Parkinson's disease. So it is reasonable not to perform any testing at this point. But neuroimaging can sometimes be helpful, especially when looking for structural lesions or trying to differentiate between our two type diagnoses, Parkinson's disease and essential tremor. Here's an illustration of a dopamine-containing neuron in the substantia nigra pars compacta, and a dopamine receptor-containing neuron in the striatum. I know, basic science. Stay with me, I promise there's a point to this. Dopamine is released at the synapse. But presynaptic dopaminergic neurons also have dopamine transporters that allow them to reabsorb the dopamine at the synaptic cleft. When presynaptic neurons are damaged, the uptake of dopamine is reduced. Enter dopamine transporter single photon emission computed tomography, also known as dopamine transporter SPECT, or a DaT Scan for short. We use a radioactive tracer to label dopamine transporters. Colors correspond to signal intensity. Red is many dopamine transporters and blue is few. Notice how the basal ganglia lights up in a normal patient. Now compare that with a patient with Parkinson's disease. In a patient with essential tremor, you would expect the dopaminergic neurons to be intact, so DaT scans should be normal. This imaging study can be helpful when differentiating Parkinson's disease from essential tremor, which is what it was designed to do. But this scan is not a confirmatory test for Parkinson's disease by any stretch of imagination. It only identifies degenerating dopaminergic neurons and not the cause of that degeneration. Look at it from a different perspective. If the scan is normal in the middle or later stages of the illness, a diagnosis of Parkinson's disease is highly unlikely. A patient with Parkinson's disease that has progressed should be losing dopamine transporters. Well, after all that, the patient actually did not have a DaT scan, because clinical presentation of resting tremor and bradykinesia is highly suggestive of early Parkinson's disease. The patient wants to know about treatments. What treatment would you offer at this point? Early treatment of Parkinson's disease may be a contested topic, but for most, there's levodopa, and then there's everything else. First, let's get the obvious out of the way. If the symptoms are not bothersome and the patient does not want pharmacological treatment, no drugs need to be prescribed. For the sake of argument, let's say the patient deems the symptoms disabling. What are some of the options? Levodopa is an amino acid precursor to dopamine that we take in and use naturally. Exogenous levodopa is transported across a blood-brain barrier. The nigrostriatal dopaminergic neurons convert levodopa to dopamine with the help of aromatic amino acid decarboxylase, package dopamine into vesicles, and release it at the synapse. Dopamine then stimulates D1 and D2 receptors postsynaptically. At the same time, unbound dopamine is reabsorbed from the synaptic cleft through the dopamine transporter and degraded by the monoamine oxidase type B enzyme in the mitochondria. So treatments are geared towards either replacing dopamine and preserving exogenous levodopa, preserving existing dopamine in the synapse, and augmenting stimulation of the dopamine receptors. For early Parkinson's disease, there are three major pharmacological options: levodopa, dopamine agonists, and monoamine oxidase B, MAO-B, enzyme inhibitors. Now, there's a debate in the movement world of what the first-line drug should be. There's even a debate that a first-line therapy is debatable. We're not going to get into any of this. Let's just discuss the pros and cons of various treatment options. When it comes to treatment of Parkinson's and some dystonias, there's just no substitute for dopamine replacement. Levodopa is the gold standard of dopamine replacement therapy. Remember, there's levodopa and then there's everything else? It is usually administered with a dopa decarboxylase inhibitor, carbidopa, to reduce its peripheral breakdown and gastrointestinal effects. Levodopa is safe and effective. It practically reverses disease symptoms for a period of time. Some resist starting dopamine replacement early because of a belief that it will become less effective and cause side effects earlier. We now understand that the shortened duration of levodopa benefit is because of progressive disease. Levodopa treatment does not seem to worsen disease progression. So until neuroprotective therapies for Parkinson's disease are available, levodopa is a good starting point. Side effects of levodopa are difficult to tease out from advancing Parkinson's disease, but they usually include motor fluctuations and dyskinesias, impulse control disorders like pathological gambling, behavioral abnormalities, psychosis, hallucinations, paranoid ideation, and that's due to levodopa-induced hypersensitivity of limbic dopamine receptors, and orthostatic hypotension, probably from central hypotensive action of dopamine. And let's not forget the gastrointestinal side effects: nausea, vomiting. We do have dopamine receptors in the gut. The other downside is the multiple times per day dosing. Dopamine agonists like pramipexole, ropinirole, and rotigotine directly stimulate dopamine receptors. Unlike levodopa, dopamine agonists are less likely to cause hyperkinetic movement side effects, especially in younger patients. Because of their longer half-life, they have the advantage of having once-daily formulations. So, why aren't these drugs an automatic first line? Unfortunately, as compared to levodopa, dopamine agonists produce more frequent cognitive side effects: somnolence, sleep attacks, impulse control disorders, hallucinations. And of course, nothing is as effective as levodopa. MAO-B inhibitors like selegiline, rasagiline, and safinamide are another option. MAO-B inhibitors prevent levodopa degradation in the brain and may offer some neuroprotective benefits, although that hypothesis did not really stand up to scrutiny. These drugs have low potency in terms of their dopaminergic effects and could potentially treat mild symptoms. Once or twice daily dosing is helpful, but patients often notice very little or no difference after starting them, so these drugs are falling out of favor. Side effects? Generally minimal, but these medications can cause cognitive side effects like confusion and hallucinations, especially in the elderly. Usually, the main issue is interaction with other medications. Do you remember learning about serotonin syndrome? A situation where dangerously high levels of serotonin are caused by combining MAO inhibitors with other medications that raise serotonin? Well, thankfully this is rare, at least in retrospective studies. Okay, back to our patient. Observation at rest revealed a mild right arm rest tremor. When holding posture, the tremor seems to disappear for a moment, but then reemerges. Rapid alternating movement testing showed a slight decrement in slowness on the left finger and toe taps. There was no slowness on the right side. Gait was generally normal, except mildly decreased left arm swing. Pull test was normal. There was no retropulsion. We offered Levodopa as the most effective treatment. The patient asks, "What are the downsides?" And you say, that's right, gastrointestinal side effects and hyperkinetic movements, or dyskinesias. Other effects like motor fluctuations are difficult to separate from progression of the disease itself. Oh, and he will need to dose himself 3 to 4 times a day. That doesn't fit with his high-functioning active lifestyle, so he said no thank you. We offered dopamine agonists. The patient asks, what are the pros and cons of those drugs? And you say? Well, they're less effective, so they work for mild symptoms, but cause less motor fluctuations. The dosing could be once daily, but they may cause somnolence, impulse control disorders, and hallucinations. He's not thrilled about those cognitive side effects. We offered MAO-B inhibitors. And how are those drugs different, he asks. And you say? Like dopamine agonists, they're less potent, which means less motor side effects than levodopa. The dosing could also be once or twice daily. Cognitive side effects are usually mild in the younger patients. After much deliberation, a patient initially declined treatment, but as the bradykinesia progressed, he selected levodopa. Fast forward 7 years. Our patient comes to the clinic with his partner. For several years, he had good control of his symptoms with levodopa, but now medication only works for an hour or so. He feels slower, more stiff, and even falls occasionally when the medication wears off. He has more difficulty with writing and less mobility overall. His speech has become softer. He also notices unwanted involuntary hyperkinetic movements, present about half of the day. More concerning, his partner reports that our patient has difficulty concentrating, multitasking, and getting words out. He is more depressed and anxious. No hallucinations, but he kicked his partner during sleep, acting out his vivid dreams. Is this still Parkinson's disease, or are we dealing with something else? Parkinson's disease affects motor function, but can it cause cognitive deficits? By the way I ask this question, you can tell the answer is yes. Patients with Parkinson's disease will inevitably experience neuropsychiatric and non-motor features, and the disability from these non-motor symptoms is often greater than from the motor symptoms. Here's a hypothetical illustration of degree of disability on the y-axis versus time in years on the x-axis. Above the midline in yellow are progressive motor symptoms, and below the midline in orange are progressive non-motor symptoms. Like most people with Parkinson's disease, our patient was diagnosed in his 50s, based on the presence of Parkinsonism, bradykinesia, rigidity, tremor. But Parkinson's is truly a systemic disease. So years, even decades before the onset of motor symptoms, in the prodromal phase, patients may start developing peculiar non-motor symptoms. Rapid eye movement behavior sleep disorder is an important one. In healthy people, movements are inhibited during REM sleep. But patients with REM behavior sleep disorder lose that inhibition, that sleep atonia, and act out their dreams. Patients sometimes injure themselves and their partners. Our patient's partner actually reported this phenomenon. Up to 4 out of 5 patients with Parkinson's have REM behavior sleep disorder. And most patients with REM behavior sleep disorder eventually develop a neurodegenerative condition like Parkinsonism, often years after the onset of the sleep disorder. So REM behavior sleep disorder is an important prodromal symptom. Non-motor symptoms progress over time. Mood disorders like depression and anxiety are reported by half the patients, but not specific to Parkinson's. One hypothesis is that Parkinson's disease may start in the GI tract, where alpha-synuclein aggregates cause autonomic dysfunction, and then propagate up the vagus nerve to the brainstem and beyond. So, constipation is another early sign, but also non-specific. There are a million other reasons to have constipation. Alpha-synuclein aggregates also deposit in the olfactory bulb early, so the sense of smell decreases. Loss of smell often goes unnoticed by patients, probably because it is gradual and mild. But hyposmia precedes motor symptoms by as much as 5 to 10 years. So olfaction testing may become a potential early biomarker for Parkinson's disease. Excessive daytime sleepiness, fatigue, and pain are some of the other non-specific symptoms that are reported early. These can be undeniably troublesome to patients. What about cognitive impairment? Parkinson's disease by itself causes little dementia, at least until very late stages. In the later stages, patients may develop delusions and hallucinations, which can be induced or worsened with dopaminergic medications. Common delusions include spousal infidelity, people stealing money, intruders living in the house, or nurses planning harmful plots. Hallucinations are commonly visual, misperceptions of forms, or formed animal or human figures. I mentioned that nearly 2/3 of patients suffer from dysautonomia. Well, that dysautonomia also progresses over time. Think orthostatic hypotension and altered cardiac reflexes, urinary and sexual dysfunction, drooling, sweating. Of course, motor symptoms also progress. Dysfunctions of the bulbar muscles causing difficulty swallowing, bradykinesia and rigidity causing postural instability, gait difficulties, falls. But like with dementia, frequent falls are usually a late symptom. Notice some words like motor fluctuations and dyskinesias on this chart. We'll get back to these in a bit. Oh no! What happened? I accidentally hit the wrong button and the whole chart got erased. You're gonna have to fix this. The diagnosis of Parkinsonism is made by bradykinesia, rigidity, and tremor. Where do I put dementia? That's right, in late-stage disease. What about rapid eye movement behavior disorder? Early. Urinary symptoms and orthostatic hypotension? Mid-stage Parkinson's disease. What about hyposmia? Prodromal symptom. What about postural instability, gait disorder, falls? Late. Nobody panic. Disaster averted. The progression in Parkinson's disease is slow, and with modern treatments, survival is about 16 years. Anyway, why did we start talking about non-motor symptoms? Oh yeah, our patient is experiencing some of these symptoms. And whenever we have new symptoms, it is prudent to reconsider the diagnosis, especially when the diagnosis is clinical and not based on a result of any particular test. The big question here is this still Parkinson's disease? Bradykinesia, rigidity, and tremor are components of Parkinsonism. Parkinsonism is absolutely necessary to diagnose Parkinson's disease. But not every patient with Parkinsonism has Parkinson's disease. Parkinsonism is just a symptom of damaged basal ganglia and nigrostriatal dopaminergic pathways. So, what other disorders can cause basal ganglia damage? Drugs, certainly. Drugs are the most common cause of secondary Parkinsonism. The main offenders interrupt dopaminergic transmission and include antipsychotic agents and antiemetics, like metoclopramide. How about cerebrovascular disease? Ischemic small vessel disease that is associated with vascular risk factors, particularly multiple subcortical lacunar infarcts in the basal ganglia, can cause Parkinsonian features, especially gait instability, presumably because strokes preferentially damage posterior internal capsule that is responsible for motor control of the legs. Chronic ischemic white matter disease can be seen on MRI. Speaking of MRI, structural brain lesions caused by disorders like hydrocephalus, chronic subdural hematoma, and tumors are typically diagnosed by brain imaging. Recurrent traumatic brain injury, think boxers or football players, certainly increases the risk of Parkinsonism and dementia. Metabolic disorders and toxin exposure. Yes, that too. Chronic liver failure, osmotic injury due to rapid sodium shifts, calcium, copper, or iron deposition in the basal ganglia. That happens with parathyroid dysfunction, Wilson's disease, or errors of iron metabolism. Metals. Occupational exposure to heavy metals, like manganese. Organic solvents, certain pesticides and herbicides. Basically, this is where your skills in obtaining a detailed occupational history could be put to good use. All of these conditions can be lumped together under the term secondary Parkinsonism, as in Parkinsonism secondary to insert disease name here. But there's another group of neurodegenerative disorders, so-called atypical Parkinsonisms, that share signs of dopamine deficiency with Parkinson's disease, but present somewhat differently. The three major conditions are called progressive supranuclear palsy, or PSP, corticobasal degeneration, or CBD, and multiple system atrophy, or MSA. The major diagnostic challenge for this group of disorders is that patients with the same pathology may have different clinical signs and symptoms, and patients with typical clinical signs and symptoms may have very different pathologies. This is a diagnostic nightmare. You gotta respect those movement disorder specialists. I don't know how they do it. For example, progressive supranuclear palsy and corticobasal degeneration are tauopathies. They're characterized by deposition of tau in neurofibrillary tangles. Multiple system atrophy is caused by deposition of misfolded alpha-synuclein, not tau. So the clinical picture is defined by which areas of the brain degenerate early and most prominently, and not necessarily by the type of protein that's damaging them. Degenerate pathways modulating brainstem function, and patient develops eye movement abnormalities and bulbar signs, and perhaps early postural instability and falls. That's consistent with PSP. Degenerate frontal and parietal lobes, and patients develop cortical and visuospatial deficits and behavioral personality changes. That's corticobasal degeneration. Degenerate the central autonomic system, and you get severe early autonomic failure with urinary dysfunction, orthostatic hypotension, and decreased sweating. add atrophy of the cerebellar pathways, and that's called multiple system atrophy. As you can see, Parkinson's disease and the atypical Parkinsonisms share the same symptoms. It's the timing of the symptoms that's different. That and the fact that atypicals progress more rapidly and respond poorly to levodopa. Mean survival after onset is about 7 years, which is less than half that of Parkinson's disease. In progressive supranuclear palsy, the widespread atrophy and neuronal loss also affects pathways modulating brainstem function. Patients with PSP often have an unusual facial expression, with deep nasolabial folds and furrowed brow, giving them an angry, puzzled, or worried expression. Vertical gaze centers in the midbrain degenerate, and patients develop supranuclear gaze palsy.
And then look down at your lap.
Especially the inability to look down on command.
Good, on the ceiling.
Limited or slowed down gaze in these patients unfortunately interferes with some basic activities like eating, reading, dressing, or even gait. To diagnose atypical Parkinsonism, you would have to rely on your knowledge of clinical symptoms and signs. There's no gold standard biomarker for that group of disorders, but sometimes you can see the pattern of degeneration on imaging. Here's a sagittal T1 MRI of a patient with progressive supranuclear palsy. Notice the atrophy of the midbrain as compared to normal. Degenerating brainstem looks like a hummingbird. Midbrain is the head of the bird. So this radiological sign is aptly named the hummingbird sign. Here's another example. What's happening here?
Is that the right hand, is it difficult to control sometimes, or it's always?
No, especially if I'm in like a fall situation, I'm trying to grab on something, I can't let go.
Make a full fist and release with the right.
Yeah, I'm trying. It just doesn't, I can't.
The right hand seems to have a mind of its own, and the patient can't control it. This finding is called alien limb phenomenon. It refers to involuntary movement activity of a limb together with the feeling of estrangement from that limb. This is a sign of cortical dysfunction. So this patient likely suffers from what atypical Parkinsonian disorder? That's right, corticobasal degeneration. Well, that was a very simplistic description of atypicals. Anyway, atypical Parkinsonisms are in the realm of specialists, so you just have to know they exist. Leave the actual diagnosis to the pros. So, the diagnosis of Parkinson's disease really involves establishing Parkinsonism, identifying supporting features, and excluding red flags. Let's apply this knowledge to our patient. Okay, I swear, this is the last time I'm going to repeat this history. Now, a 64-year-old man with slowly progressive right hand rest tremor and left bradykinesia, with decreased fine finger movements, difficulties with mobility and occasional falls, and REM behavior sleep disorder. He initially responded to levodopa, but now reports diminished effect and disabling hyperkinetic movements. So, does our patient have Parkinson's disease? We have already established Parkinsonism with bradykinesia, rigidity, and rest tremor. Symptoms were unilateral in onset and slowly progressive, and our patient responded to levodopa, at least for a time. So far, so good. Are there any exclusions or red flags, symptoms or history that's unusual for Parkinson's disease? Levodopa is less effective now, but he did have a good response in the beginning. Our patient does have REM behavior sleep disorder. He acts out his dreams. And he does have mood changes. But we established that these are earlier signs of Parkinson's disease, and it would be unusual to have prominent motor features without any of the non-motor signs. Our patient does report occasional falls, but this symptom wasn't early or prominent. He doesn't seem to have dementia or bulbar dysfunction, difficulties with speech, swallowing. Dysautonomia is a symptom of mid to late stage Parkinson's disease. But even 7 years into his illness, our patient does not report significant orthostatic hypotension or urinary incontinence. Finally, our patient denies history of predisposing conditions like previous strokes, repeated head injury, neuroleptic treatments. So, based on all this information, we are still convinced that he suffers from advancing Parkinson's disease. What do we do now? And this brings us to the last part of this talk, treating advancing disease. We used the term Dyskinesias before when we discussed Levodopa. What are Dyskinesias? Where do we place them on the movement phenomenologies chart? Well, dyskinesia is not a specific movement. It's basically a term that encompasses a variety of hyperkinetic movements and postures, including dystonia, chorea, tics, and very rarely tremor. This term actually refers to two entities: involuntary movements that appear late, several weeks to months after initiation of dopamine-blocking psychotropic drugs. These are called tardive or late dyskinesias. This is probably the most common use of this term. But also this can apply to levodopa-induced movements that appear relatively early in patients with Parkinson's disease. So, dopamine replacement is not without its challenges. On this illustration, theoretical brain level of levodopa on the y-axis is graphed versus time measured in years on the x-axis. Imagine snapshots in time where the same patient keeps taking levodopa. Brain level of levodopa rises, and patient experiences improvement of Parkinsonian symptoms. That's called the on state. Initially, this benefit may last as long as a day. When levodopa level drops, the response to dopamine replacement wears off. That is the off state. Over time, the nigrostriatal dopaminergic neurons continue to degenerate, losing their ability to store and release exogenously administered dopamine. At that point, levodopa's maximal benefit and the duration of that benefit declines to as little as an hour or two, mirroring the drug's rapid metabolism. Overstimulation of dopaminergic neurons causes levodopa dyskinesias, dystonia, chorea. At the same time, patients experience worsening motor fluctuations, swinging between periods of positive response to levodopa on and periods where Parkinsonian symptoms reemerge, off. A particularly extreme and debilitating example of a motor fluctuation is gait freezing. Patients describe brief episodes of feeling that their feet are glued to the ground and they're unable to generate effective stepping. It is most prominent during turning, step initiation, but also when faced with spatial and visual constraint. A tight, cluttered hallway, threshold between rooms, or a change in the color of the floor. So clearly, the aim is to minimize off periods and maximize on periods while avoiding bothersome dyskinesias. Most of that is accomplished by optimizing levodopa dosing and mode of delivery, but we have some other options. How about adding an NMDA receptor antagonist amantadine? That may help patients with prominent tremor or dyskinesias. but this drug has significant cognitive and behavioral side effects. Dopamine and acetylcholine are normally in a state of electrochemical balance in the basal ganglia. But in Parkinson's disease, dopamine depletion produces a state of cholinergic sensitivity, so that cholinergic drugs exacerbate and anticholinergic drugs improve Parkinsonian symptoms. Anticholinergics can treat tremor and dystonia, and those peripheral muscarinic effects can help with drooling, excessive salivation, and urinary frequency. But unfortunately, this drug class worsens memory impairment and has other cognitive side effects, especially in older adults, and makes tardive dyskinesias more pronounced. Oh, and those peripheral antimuscarinic effects can also become a side effect, causing dry mouth, dry eyes, blurred vision, constipation, urinary retention, impaired sweating, and tachycardia. Another option to smooth out motor fluctuations is to enhance the plasma half-life and bioavailability of levodopa. This can be accomplished by inhibiting the catechol O-methyltransferase, COMT, enzyme that converts levodopa to 3-O-methyl-dopa. These so-called Capone drugs may improve levodopa's end-of-dose wearing-off time. Unfortunately, in later-stage disease, adding a COMT inhibitor may exacerbate the peak-dose dyskinesias. In such cases, reducing the levodopa dose can be a solution. Also, some of the older Capones have a risk of liver toxicity and severe diarrhea. At some point, there comes a time when medical therapies no longer adequately control the symptoms. So it's time to move on to surgical options, and the most common surgical option for the treatment of Parkinson's disease is deep brain stimulation. Through a small burr hole in the skull, DBS electrodes are implanted stereotactically into the appropriate cerebral targets, usually in the globus pallidus or subthalamic nucleus. The implanted leads are then connected with a wire that is tunneled under the skin to a pulse generator implanted in the chest wall just below the clavicle, like a permanent pacemaker. When turned on, the battery-powered pulse generator delivers high-frequency electrical stimulation. What's really nice is that this electrical stimulation is programmable and reversible, so no brain tissue is actually being permanently damaged. DBS has been shown effective for the treatment of tremor, dyskinesias, motor fluctuations, dystonia, and the effect is sometimes almost miraculous. So, if DBS is so flexible and effective, why don't we just use it earlier in the disease? Well, deep brain stimulation is still brain surgery. Serious adverse CNS events like infections, intracerebral hemorrhage, and seizures are rare, less than 3%. But hardware is hardware. Any hardware can cause problems. Up to 1 in 6 patients need electrode or wire replacement, lead repositioning, or replacement of malfunctioning pulse generator. What happened to our patient? Well, he eventually had a deep brain stimulator implanted. And here's an example. DBS off. DBS on.
How you feel? A lot better. Yeah. Excellent.
Wow. I tell you what, this device never ceases to amaze me. Congratulations, you made it through. I realize this was a long talk, a lot of information, but you expect nothing less of us, right? Be honest. Thank you for joining us. Until next time, neurophiles. Bye.